session today is session 5 for implementing self-measured blood pressure. And we're going to talk about starting your SMB program. So a little more information on that than maybe we've been discussing recently. Our objectives for today are to discuss the care team roles for the members of your team. Look at how other ways or discuss more about what to do before you start your SMB program. And then also we're going to look at some clinical support examples. And like we do every week, we're going to start with some polling. So Elena is going to pull up the polling questions.
Yeah. So the first one is, when completing a device accuracy check, how many total measurements are taken? And then the second one is, it's important to complete a device accuracy check at what frequency? All right, so the answers for this one, there are a total of 5 measurements that are taken on the device accuracy check. A few of them are from the in-office blood pressure machine, and then the others are from the device that the patient is taking home with them. And we definitely want to complete the device accuracy check for every new device, but then on top of that, annually, we also want to double check and make sure that those devices are accurate. So, with that, great job.
And then the other thing that we like to do every week is just take a moment to have you share about maybe what you learned or how you incorporated what you learned on our last session into the work that you're doing with your SMBP program. So Teresa,
yeah, right.
If you want to share a little bit more about your process, or if you were able to put in place a process for completing the device accuracy checks, and if you want to just share a little bit more about that.
So I forwarded the information about the accurate devices to management, just because the ones that we have are not on it. So I don't believe we'd be able to build those codes now with what we have, the supply of. Nurses are, already handing out the cuffs, showing patients how to use it, that sort of thing. The education that was given, I forwarded some of that to the clinical team too. I think there was a form. No, I'm looking through my notes, I can't find it, but it showed the order to take to validate. So they have that. We don't really have a process for the patients calling in with blood pressures. I mean, they do, but we don't have a process for billing that at all, because it just kind of goes into like a telephone communication. There's no grid or billing piece to that. I mean, we're doing bits and pieces of it, but we'd have to get all new devices and come up with some protocols. So that'll take time.
Yeah, I was going to say we're going to say something, Elena. I'm sorry. Go ahead.
Oh, I was just going to kind of follow up. I did reach out to, his name was Dr. Ray Coates, and he's, like I mentioned last week, he's part of the team that created the CPT codes. So the first question I asked him was, does 99474 have to be attached to a visit? And he said, no, it's not meant to be used with a visit. Okay. So first point of good news, hopefully.
I don't know how we would get it to the health plans if it's not, though. So if it's not an encounter, but that's billing that I don't know. So
yeah, so he was super quick to answer me back. So I can reach out to him with more questions too. Like if it's not an encounter, how do you see it being used is kind of the question.
Yeah, and that might be something our billing already knows. I just don't personally know if it's not sent through on a claim, how it gets there.
Yeah. The next question we asked was about that list, and when do they think that more devices would be added. And basically they said it's ongoing. What has to happen is the manufacturers of the devices need to submit to be listed. So that could mean that like Medline, it is clinically validated. They're just not on that list quite yet. And if you do have a relationship of or whoever ordered those devices has a relationship with them, they could kind of mention that that's kind of something that would be important to you guys. And then the next part that kind of goes along with that is that I mentioned that we work with people that don't have the devices that are on that list, whether they got them before the list came out or didn't like there's nothing in that CPT code that links directly to that list or anything like that. So I kind of asked about that too. And he said, many devices are actually validated, but they're just not on the list. And CMS did not define validation. That determination usually happens before it goes on the market, and calibration, which you are doing, is most important, but a separate issue from validation. So I also think that was kind of like a wishy-washy answer. So I'm going to ask him for a little bit more follow-up on that. But I do think that means that you could also reach out to the manufacturer and ask them if their devices are clinically validated. And they very well could be. They just haven't done that submission process like I mentioned. And if that's the case, then absolutely, it sounds like you can definitely use both those CPT codes and get the reimbursement from that. So I think that's all really good news. I think because the whole point of CMS did not define validation, it's open for interpretation. It doesn't necessarily mean that list is the end all be all. I mean, it's been around for almost a full year now and it hasn't grown. So that really leaves kind of clinics throughout the country very limited on what they can provide to their patients in order to get the CPT code reimbursement. So this is good news, I would say overall. I did mention to him the devices. So if you do have more, if you can provide me with the full name of the device. I know last week it was Medline Automatic, but if anyone at your organization knows, I can send him that one directly and see if he already knows that that's good to go. And I can forward that information on to you as well.
Okay.
And then we just asked him another question. I think in 99474, it talks about just an eligible provider. So we just asked kind of what that term, like who that reference is. And so he just said eligible provider is typically someone who is a provider for Medicare.
Oh, okay.
So we're pretty open there too. So hopefully those kind of help. I know that since they're pretty new codes in this world, that they're still trying to figure it all out as well. But I especially think that kind of knowing that many are validated, they're just not on the list, is a good distinction. It's not something that I'd heard kind of advertised widely in many of our calls. It had always been like, this list is like the best practice, this is what you want to do. But since that list isn't growing and it contains a lot of very expensive devices, hopefully there are plenty of other devices that are out there that have been clinically validated, but just not added to that list.
Okay, good.
Okay. So if you think of any other questions around CPT coding, like I said, he was super open to answering questions. So feel free to let me know and I can reach out to him. Obviously, it benefits us to know all the answers to this too, so we can help out whoever else might come with questions in the future.
Okay.
Thanks, Selena, for reaching out and sharing those. And I just wanted to say hi, Wendy. So, hi. We're just getting started and I see you're eating your lunch. We're just doing round robin. So if I don't want to, I know you guys are both probably on your lunch hours. If you want to, what we were talking about in round robin is just, if you had anything you wanted to share from any processes that you may have been able to put in place from our session 4, and that was around completing the device accuracy checks, and if how you might have done that. And if it's easier to, Wendy, like I said, I can see you're eating lunch. If you want to just put in chat, maybe what you've done when you have a second about any follow-up that you had from session 4, I think that would be just fine. Thanks, Wendy. And we will move to our next slide. So we're going to talk next about the roles of the members of your care team and do a little more definition on those. So we're going to start with, as you can see, this resource here on this page is from the National Association of Community Health Centers, and it's shows kind of the scope of practice for SMB support for the providers in your clinics. So some of the things that fall within their scope of practice, or their tasks, I should say, for each of the different team members. So what you can see here in this example is that things such as diagnosing hypertension and prescribing medications are done by a licensed clinician. Things that your non-licensed people can do within your care team are things such as providing training on using the blood pressure monitor and the blood pressure cuff, of course, and then providing outreach and support. And then there's also a few examples of some optional tasks for your non-licensed staff people. And then there's also some examples of that the patient needs to be doing, such as taking their medication and taking the blood pressure. And you can find the link for this guide at the bottom of this slide. Next, we're just going to talk a little bit more about, in some more additional detail, talk a little bit more about those tasks that we were just looking at. And again, this falls within the scope of practice for each of those team members for your SMBP program. So as you can see here, medical assistants play a key role in your SMBP program. They can measure and record blood pressures, and they can provide the patients with information and instructions that has been authorized by the physician for them to share with the patient. And then they can also do any communication that's not related to non-triage, or that is non-triage. If you have community health workers that are part of your team, they're really there to help empower and coach your patients. They serve a key role here. They can provide social support and help your patients with their goal setting, and also help them better identify, maybe those barriers that are keeping them from measuring their blood pressure at home, or maybe following up on taking medications. They also can serve as that liaison for the patient and the clinical team. So of course, anything that the community health worker is learning from the patient needs to be shared with the clinicians on the team. And then they can also engage patients in preventive care practices, chronic disease management, and other self-management practices. One of the things, you've probably heard this before at any session such as this, or any other type of session where we're talking about the scope of practice for your team members, is we always want to encourage your team members to work to the top of their licensure, so that everyone feels like they can contribute the most to making this a successful program. On the next slide, we talk a little bit more here about those things that fall within the registered nurse's scope of practice. So of course, this is measuring and recording the blood pressure. The RNs also are there to teach the families and the patients about the care and the prevention of the illness, or so prevention of hypertension in this case. They can administer medications and treatments that, again, are prescribed by a person who is licensed to do so. And then they also help coordinate and deliver a plan of care with members of the care team. So everybody, as you can see, works together here. We also mentioned here the billing team. So it's really important for your billing team. I think you're just talking about that, Teresa. The billing team needs to really know and understand the SMB billing CPT codes, so that your clinic can get reimbursed. And then lastly here, I want to talk a little bit about the pharmacist. I'm not sure if everybody has the availability to have a pharmacist on a team, or at least that you be able to consult with a pharmacist if they're maybe not there on site with you. But the pharmacists are there to make sure that medications are consistent with the medical prescription order. So making sure those medications that the patient has are those that have been prescribed. They can review those medications with the patients, of course. And again, the pharmacist, just like everyone else, needs to be there to consult with the other healthcare professionals on the team. I mentioned here too in the last bullet point, medication therapy management. I know that in Minnesota, we've had medication therapy management, but you want to check with each of your own state boards of pharmacy to see what the parameters for medication therapy are within your state. And those two can then be incorporated into your SMBP program. In here, we just have a few resources that you can refer to for medical assistants and community health workers, just some helpful links to some resources. And now I want to talk a little bit more about getting started with your SMB program. On this slide, what we're looking at is a few steps that are necessary for the implementation of your SMB program. If you look at there's a link to at the bottom of this slide that will take you to the site where this picture that I have here is already housed. And if you go there, you can actually click on each of the buttons. They aren't going to work on the slide, but if you click on each of the buttons, it will bring up more education. So more education about methods for monitoring, how to teach SMBP patients, using EHR technology more effectively, communicating with patients. So it's really kind of a very helpful little site that you can use. And again, it brings you up to more resources that you can use as you click on each of the buttons. So I'd highly encourage you to go to that website. So just a few more things to discuss here as you get started before you start with your SMB program. You want to identify at least one of the providers on your care team to serve as the champion. It's just like probably other programs that you have put in place within your clinics. You always want to have a clinic champion who's there to, be the cheerleader and also oversee and make sure that the program is moving forward. Also, make sure that you're allocating appropriate time for things such as training patients for SMBP. Usually it's going to take 5 to 6 minutes at least per patient on training them on the SMB program and using the cuff. Make sure, again, that you have time in place to ensure device accuracy, especially if the patient is using his or her own device. So that usually takes about 5 minutes. You want to look at averaging and documenting the patient's SMBP readings. That's just usually 5 minutes. We'll talk a little bit more of that, but as you know, we want them taking more than one blood pressure. So you want to make sure they're taking them, and then you can average those. And then also you want to allow 5 minutes to prepare the device for the next patient. And then also making sure you're allowing time if you're doing a loaner program that you've put time in there for that. You don't want to forget the infection prevention strategies that we learned from last week, to have time to put those in place also between your patients. So when you're looking at designing your SMBP program, make sure that it includes how are you going to identify those patients who are candidates for SMBP? And we'll talk a little bit more about that later on in today's session. Who will you have train the patients on self-measurement? And so again, putting your team together, what team members, and again, considering their scope of practice, who will be the ones who train? How are you going to get the readings? And if you're using a loaner program too, how are you going to get those back from the patient? Do you need to have appointments? And, probably better to schedule them before the patient leaves and, having them call in or trying to get them scheduled after the fact. Who's going to be responsible for averaging, documenting and notifying the physician of the SMBP readings? And how is follow-up going to occur? So just a few more things when we're talking about starting your SMB program. This is more about with the loaner program, but again, who's going to track the distribution and return of the devices? We talked a little bit about that tracking form last session. So that might be something you want to put in place. Who's going to be responsible for disaffecting and returning the loaner devices? Is it going to be just one team member, or is it going to be specific people, specific days? So just make sure you have a process in place for that. And where are you going to store the loaner devices so everybody knows where they are so they can find them when they need them. So we talk a little bit more about how we're going to identify our patients who are eligible for SMBP. So when you're looking at your patients, you're going to start, of course, probably with those patients who have a confirmed hypertension diagnosis. It's good to encourage these patients to get their own validated SMBP device if they can, if you don't have a loaner program, of course. If they can't afford their own device, then of course, offer something through a loaner device. And then, as we said, if they do have their own device, just make sure that you can validate with them that you're getting correct readings. Also, you might want to look at those patients who don't have a confirmed diagnosis of hypertension, but are at risk. So these are the patients who are maybe what we call, the borderline hypertensions or pre-hypertension patients. And those that you suspect who have hypertension, maybe because of white coat syndrome, and maybe now with COVID, that they're wearing masks. Are their blood pressures, are they more anxious, and that is causing their elevated blood pressures? The other thing is just to make sure when you're identifying patients for SMBP that these are patients who will be willing to monitor their blood pressure at home. So, if there's patients who you don't think are going to be compliant, they're probably not a good candidate for the SMBP program. And the next slide. We want to look at what are the methods you're going to be using for obtaining the patient readings. Are you going to, get them via telephone, a secure fax if you're going to have them fax in? I don't know how many people, might be using fax for this, but that is an option. Online through a secure patient portal or through telemedicine website. I think a lot of clinic systems nowadays do have things such as MyChart or some type of system where they can share information that needs to be followed up on. Also, are you going to schedule any follow-up office visits? Again, make sure you're using tracking cards and when you do this, reviewing the device measurements, and download the measurement if a history is needed. So if the patient has, sent you in some blood pressure readings via, something such as MyChart or online, make sure you have those available when they do come in for their office visit. And then also make sure that you've averaged all the readings taken by this patient into a single reading, your systolic and diastolic blood pressure readings when they do come in for that reading. So also when we're talking about, these were just some of the resources. I know we talked a little bit about some of these last week, but just we're talking about BP tracker cards that you can use, patient portal. There's also options from home medics devices because they have their own tracking within the device. So just kind of wanted to remind you of that. Here we're looking at an SMB workflow that an example of one that you can put in place within your clinic. And again, the link is included on the slide here where you can access this and print it off for yourself. But when we're looking at a workflow, so again, you don't have to start from scratch. It's about identifying the patients who have benefit from the program. So these are the things we already talked about. Those who have hypertension, those who have white coat syndrome, those who just really need to improve their treatment that they are already been on hypertension medicines for a while and just maybe aren't getting good control. Make sure you're training your staff on the correct use of SMB techniques, and then checking their competencies, so not just training, but also having them test out on it. Train your patients on how to correctly self-measure their blood pressure. Again, show them how to do it, do the teach back so that they know that they're doing the correct procedure at home. You can recommend automated upper arm SMBP devices too, if that is easier for the patient. That's something that they need to do. What you're going to do if you receive SMB data from patients. Also talk to, so just a number of the things that we've already talked about, looking at the accuracy and then ensuring your patient's devices fit properly. So things that we've actually covered through a number of our sessions that we've already had, but this is just kind of a nice little checklist all in one place that you can use. And this slide shows us how you can interpret those readings when you get them. Again, a lot of this is things that we've talked about in some of our previous sessions. But if a patient has a blood pressure reading when they're in the office, so all these readings are in the office. If it's 120/80, you know what? You just need to recheck them in 1 year. So if you've got a patient who is 120/129, but for their systolic, but their diastolic is less than 80. That's an elevated blood pressure. So you can give them, coach them on healthy lifestyle changes and recheck their SMBP in like 3 to 6 months. And some of these things too, as part of your SMB program, you're going to want to make sure that you have a protocol within your clinic. Because I know when we've worked with some clinics in the past, some physicians, they might not see this patient in the second example for another year. So it's something you kind of want to make sure that everybody's following the same practice within your clinic. If it's less than 130/80, this could be hypertension that, they might be hypertensive, but maybe it's just not showing up. You want to manage hypertension. You want to make sure they're managing their hypertension because they are at increased risk for cardiovascular disease. And then you could consider a 24-hour ambulatory blood pressure monitoring for a patient such as this. If they're greater than 130/80, recheck again in 6 months. And then you also might want to look at white coat syndrome for someone who is greater than or equal to the 130/80. Again, look at lifestyle changes and recheck them in 3 to 6 months. And then if they're greater than 130/80, make sure you're managing per current hypertension guidelines. So these are just things that, I'm sure you all are aware of, but just kind of put again in a nice little slide for you that you can also share with your other team members. So when you're providing feedback, SMBP is associated with better blood pressure control, and it adds clinical support. So there's different things that you can use when you're providing feedback. You can give web-based feedback to your patients. You can provide it over telephone. Again, I think the biggest thing when you're starting your patients on an SMBP program is just finding out what is their, preferred method of feedback and how do they want to be worked with. What's easiest for them. Not everybody has access, to computers, and so maybe they prefer talking over the phone and getting counseling that way. And you just want to make sure that, you're reaching out to them and getting feedback and, providing them with feedback, but also getting feedback from them on what is and isn't working for them. Behavioral management also, if you have behavioral management teams or processes or protocols that you use, those can also be used for educating patients and helping them focus on improving their hypertension and better managing their hypertension. They can cover topics such as things of, how knowledgeable are they as their hypertension? Do they know what resources are there for them? Do they know what some of the behavior changes we're asking them to do? Things such as lowering their salt intake, exercising more. And then also stress management is a big thing too that you can discuss with your patients when you're talking about behavioral management. Also tobacco cessation, we haven't talked about that yet today, but we've probably talked about it every other week is always a big one. And diet and exercise are big ones. Next, we're going to talk a little bit about some clinical support examples. We have another slide here that looks at a workflow to help you this one's more of a visual workflow for your SMBP process and what it could look like in your office. And just so you know too, this slide is that link we referred to. I didn't add it to the slide, but it's the same slide or the same link from slide 13. So just as I said, we looked at the process previously today, but this is just more of if you're a visual person, how you can set up your SMB process within your clinic. And then here too, we have another workflow example to help you visualize the workflow within your clinic. Just trying to give you a couple different ways you can look at what you want to put in place within your program. Again, we're starting with which patients do you recommend, and does the patient agree to do the SMB program? I think that's a big thing too. We just really don't want to overlook when we offer this to patients. Sometimes I think we can offer it to patients. We go through everything and we've never really had them agree to doing this at home. So, that's kind of something upfront, to see if they're willing to do it. And some just maybe want to learn more. And after they learn more, might not want to do it, but I think it's just really important to make sure that the patient is agreeable to doing the SMB program first. And also at the top of the slide is the link to where you can find more information about this process. Some more clinical support examples here. We're talking a little bit more about ways you can counsel or work with your patients. So there's one-to-one counseling. As I said before, if a patient, you can talk to them via telephone. This is something also that you could do online. It wouldn't necessarily have to be via telephone, and provide them that ability to talk to nurses or pharmacists or anyone who can help them manage their medications. Especially now with COVID, it's kind of important to make sure that one-to-one counseling is available, especially since people aren't coming into the office as often. And community health workers also, if you have them available to you, are a really important part on this one-to-one to help them. They can relay information that they've maybe heard from the patient in their sessions. When they've talked with the patient, and make sure that that's getting back to the clinicians on the team. But it's sometimes patients might be willing to talk to a community health worker and share more with them. But again, we just want to make sure that the clinicians are aware of it and we're not, that we're closing that loop. Again, when we're talking about patient education, nurses can be the ones who are providing those telephone or, telehealth or even online support services. Also, even online, you can form some small group classes for SMBP and lifestyle changes. If people are, tech savvy and they want to do Zoom calls online, that can be led by a clinician and have kind of that small group classes for SMBP. That's another opportunity. And of course, if people are coming in person, then you can do that too. Just kind of remember the COVID restrictions. Everybody needs to be masked and 6 feet apart. So might be a little easier to do Zoom maybe, but so again, we're just continuing here, just a few more clinical support examples for the web-based or telephone support-based. We've talked a little bit about these, but the computer and telephone, so that would be like your Zoom calls if you want to do group classes. Also, if you want to share web-based tools, of course you can share hard copies with patients, and some might prefer that. But if they prefer to go online and get some of the tools, we can share some links with them. And then maybe texting and emails are another opportunity to keep in touch with patients and get feedback and share it that way. Just make sure that you're using secure messaging both with your clinicians and staff with the patients. And lastly, we want to talk about sustainability of your program. So a lot of this is just a little bit of review of what we talked about here today, is making sure you've got that champion within your clinic who's there to make sure that the program is getting those things it needs, and that is there to provide you with things such as resources. You want to have those in place. Make sure you have everything in place if you're going to do a loaner program. And then also, this is a little bit back to the billing too, talking about health insurance coverage for at-home devices. So some things you can look into if you are going to have a loaner program, or even, if you're connecting your patients with maybe some companies where if they want to purchase their own. So health insurance coverage for Aetna and Cigna provide coverage at home for monitors is one example that you can look into for your patients and how they can use that. Some other ones are, and these are just some insurance companies we're aware of. We realize that not everybody would have access to these in the 3 states, but these are just ones that you could look into. Other ones, are probably more state specific, such as, UCare in Minnesota, or, Medica, or some things you could look into for Minnesota. I'm not quite as aware of the health insurance programs in Michigan and in Wisconsin, but that might be something that you can look into. And if you have some questions, we can certainly help with that too, if there's more that you want us to look into. So here in the next slide, it's just an example of some of the different payment reform and how providers may be reimbursed for SMBPs. So, and this is another slide. If you, it's from that link from the slide on slide 13. That website actually has quite a bit of information on it. So, it talks about how healthcare reform is shifting from fee to service for pay for value reimbursements, which I'm sure you're all aware of. But this supports the compensation for self-measured blood pressure monitoring. So Elena talked about that last week, and we were talking a little bit about that at the start of the call too, some different ways that with billing that you want to make sure that your billers are aware of, so you can get reimbursed for these programs. As it says here, currently reimbursement for SMBP varies by health plan. For both blood pressure monitors and the service of monitoring blood pressure. So again, you want to make sure you kind of look at what your state guidelines are and how some of that is reimbursed by your state healthcare plans. But there are also some group purchasing options you could look into. And then also some medical practices, as we've talked about, if you want to do the loaner programs, that's something you can offer. Teresa?
Yeah, I'm sorry. Did we, or you might be going into it, did I already ask about Medicaid reimbursement for the code?
I don't know if you've already asked about it, and I'll be honest with you. So too, for because you're in Michigan, right, Teresa? Yes. Because I know too, Medicaid coverage varies per state and per plan, probably too, within, how people get their Medicaid set up. So that might be something I'll be honest with you, I'm not totally familiar with Michigan, but we can certainly, do you have like a specific question, just what the coverage is from Medicaid?
Yeah, just because we're a federally qualified health center, there's certain codes that we just can't bill, I guess, is what I've been told in the past. Some of the care management codes that are out there, we aren't able to bill Medicaid. I don't know if it's a duplication of service or part of that fee for service contract that we can't do anything outside the visits billing wise. I'm not sure. So I can check with my billing too. Just couldn't remember if I'd.
And you might have asked it, and I'll just say, I'll go with my faulty memory. I don't remember asking it before, but it's actually a good question. So we can do a little. I don't know, Elena, because Elena's in Michigan. I don't know if you know anything more from Michigan for the Medicaid.
I personally do not know very much about from the Medicaid point of view, but I can definitely look into it a little bit more. I know that, like, for instance, the information that's on the slide right here, that came directly from that Dr. Raycote's presentation. So the fact that it kind of specifies CMS over just Medicare, it would kind of lead me to believe that there is probably some funding available for Medicaid as well. And historically, I think too, Medicaid also at one point at least did kind of provide blood pressure monitors to their patients. So they might be a little bit more, have more opportunities for reimbursement like this too. So something we can look into a little bit more. I know we tend to focus on the Medicare side of things here. So, but that's something we can look into.
Yeah. No.
And on the Medicare side, they would have a patient responsibility. They would be responsible for the part of this code.
The 20%, is that what you're thinking? Because most Medicare money.
Yeah. So we were talking about that because we just, before we asked if they wanted to enroll, we have to make sure that they are willing to pay their responsibility every month.
And they need to know too. I mean, that's great too, Teresa, to let them know, because people do want to, sometimes patients aren't as familiar with what their Medicare covers. So no, I think that's a good point. And as far as I know, and again, correct me if I'm wrong, Elena, they would still be responsible, just like for other services, for that 20%. Yeah. So as Elena said here, so here's just some of the different CPT codes for SMBP that can be, or the codes that can be used. You want to make sure that the device, of course, is validated for clinical accuracy. It can be submitted once per patient. And then for staff time here, it's $11.19 for the patient education that you can bill. And then here's we also have some link here where you can easily find devices validated for clinical accuracy. I think we've already talked about that last week and a little bit this week too, that, hopefully they'll add to those lists, because there's not as many devices on there as we'd like to see. And then just some examples of patient education training and device calibration resources. And again, I know some of these were covered last session, but we just wanted to make sure you had those links. And then here, just a few more things on codes for SMBP for billing for that. It's kind of, I don't mean to say it's a repeat of the last one, but we do have a little bit more information on the code here. You want to make sure that, again, when you validate that device, that you can, have that recorded so that in case CMS asks for that you can prove that you validated the device. One thing too that we didn't talk quite as much in the last slide was the measurement protocol. They're looking for 2 blood pressures, 1 minute apart, and then you do that in the morning, and then also in the afternoon or in the evening for 7 days. So they, are looking for a minimum of 12 readings. And then also make sure data collection reporting require documenting and averaging both the systolic and diastolic blood pressures. So that's something you'll need to make sure to show. There needs to be documentation of communication of the treatment plan. Also, for that you for the 30-day period, that there's a minimum allowable for the repeat code submissions. So you can only do this once per month when you submit it. And then unlike any remote monitoring CP codes, there's no digital or electronic requirement for SMBP data return for this one. So action planning for next week. First, I should just check, are there any questions about what we covered so far? Then our action planning for next week. So there's 2 slides on this, just so you know. How will you get the self-measured blood pressure readings back from your patients? So are you going to do electronically, via telephone? Who will be responsible for averaging, documenting, and notifying the physician of the SMBP average? How will you provide feedback to the patient? Then also on the next slide, we're going to talk a little bit about if you have a loaner program, just to remember, how are you going to track the distribution, return of the devices? How will you get the devices back? Who will be responsible for disinfecting the return loaner devices, and where will the loaner devices be stored? So a little bit about, looking back on what we covered in our last session. So that's all I got for today. Any questions or?
Not a question, but it just gave me a really good idea. You had thrown in the part about referring to the pharmacist. We do have pharmacists on staff, as well as we just started a program for a food pharmacy for patients with diabetes and heart disease, and this would be a great thing to roll into that. Healthy food, checking your blood pressure, get with the pharmacist, that trifecta. That'd be really good.
No, definitely, Teresa. That's a great, as we talked about in some of the earlier slides, it's not just about medications. And I mean, we focus on the medications and the blood pressure readings, but, there's a lot to lifestyle with blood pressure too. So, the food is a big part of it. So education on that. And I think that's a great idea, looping in that food pharmacy. I got the name right? Is that what you call it? You said food pharmacy.
Food pharmacy. Yeah.
Okay. Yeah. All of a sudden I thought maybe that's not what she said. And I totally understood. But
and we actually, in that program I mentioned in Missouri, we actually work with a lot of clinical pharmacists that have taken on the role of providing the SMBP program. So they've kind of chosen to be the clinic champions and have really spearheaded it. And they're the ones that kind of reach out to the patients, send them reminders, all of that. So I definitely think if you want to make this program really successful and you want to reach out to someone outside of what you originally might have thought of, I think a clinical pharmacist or a pharmacist in general is a really great choice. We like working with pharmacists a lot in a lot of different projects because I feel like they're pretty underutilized for all the things that how the people that they can reach and how they reach them pretty often too, because patients are coming in pretty frequently to get their refills and all of that. So I think it's a really good route to go.
I think, we had that slide too that referred to the medication therapy management program. So again, I'm more familiar with Minnesota, but I'm guessing in Michigan, that's probably also quite active. So I think it's a great way to bring in the pharmacists. Like I said, I'm never sure how much, some clinics have pharmacists right on site, some don't. And so, but if you have pharmacists you work with, I think it's a great way to get them involved. Well, if you don't have any other questions, I want to thank you, Teresa, and I see Wendy had to drop off, but
thank you. I feel so special.
It's a 2-on-1.
I was going to say, Wendy, you always ask such great questions, so I hope you don't mind. I know it's kind of, I think Elena had mentioned too, we've run into, people sometimes they're running the COVID immunization clinics too, so it's just kind of a hard time. So we don't want to say that that's more important than blood pressure, but understand if that's what people have to do. And I know, Teresa, too, that you, share this information. I know it's maybe not you per se who's doing the program, but I appreciate how much you're sharing within your clinic and finding back from them what they're doing. So I thank you a lot for doing this.
Yeah, I appreciate your time too. Thank you.
Well, we will see you next week.